Okay. All right. Can we just say thank you very much to that panel? I'm sorry it's distracting me. So much. And we do have one more panel right now on research in equity, in stillbirth equity. And so if Tsega and Naomi, Tsega, Naomi, and Sarah, where's Sarah? There you are. Come on up. Yeah. Okay. I know it's the end of a long day, but there's still more that sort of more that we have an opportunity to learn from, and I hope that you can kind of hang in there with us over the next couple of sessions. So right, we're switching laptops as well. I'm sorry. So anyway, I'd like to introduce Dr. Tsegaselassie Workalemahu, who is a genetic epidemiologist at the University of Utah, and Dr. Naomi Riches, who is a member of the Stillbirth Research Program here at the U, and Sarah Lopez, who is a senior clinical research coordinator also at the University of Utah. We're just almost there, I think. Yeah, Naomi and Sarah, you want to come sit here while you're waiting? And I'll hand it over to Tsega. Thank you.
Thanks so much. Thanks so much. I just want to thank the organizers of this symposium, excellent symposium, the families that are here, and friends that come to visit us from far away. I want to thank everybody. I'm very excited to share with you a little bit about what we do here at the University of Utah, and also highlight our research team here. So as mentioned, I'm a researcher focused on investigating genetics in complex issues like stillbirth. So a big part of what we do here is called study of familial and genetic determinants of stillbirth, emphasizing families here, if I can point, emphasizing families here with the inclusion of dads, moms, babies, and siblings. So our effort includes investigating inherited factors in families by including other members of the family, including the dad and siblings. So these are kind of a micro level investigation to find genetic causes to explain to grieving families, not only that, but also inform clinical guidelines for prevention in future pregnancies. Of course, stillbirth is complex, which means that there's many factors that contribute to it. It's also relatively common. So often for complex and multifactorial issues like stillbirth, population-based data is critical. So I just want to highlight a couple of slides to tell you a little bit about what we do here in Utah and the teams involved in this to generate population-based data in stillbirth. So a big part of what we do is to understand how stillbirth affects families here. We just heard from Dr. Page earlier. She's one of our providers who's also involved in stillbirth research. She and I initially requested data from the Utah population database. And initially, this is the shape of the state of Utah where we are right now. Initially, our project was to look for a familial aggregation, to understand familial aggregation using this data for stillbirth. And this is kind of highlighted here using the pedigrees. So what we did is we looked for we used the state's fetal death certificates to identify stillbirth and match those with live birth from birth certificates. And initially, so we wanted to understand the inherited predisposition to stillbirth. And this is by no means a comprehensive investigation of all families that have suffered stillbirth, but it was a good starting point. And part of that effort is also to enroll families to understand how it affects them. So I urge folks to reach out to our investigative team, Dr. Silver and Dr. Branch, and to okay. I'll use this. Everybody can hear me okay? Okay, thank you. So I urge everybody to reach out to our investigative team to enroll in this study, because we're currently enrolling not just in Utah, but families who have been affected by unexplained stillbirth. So so what I want to mention actually is what we're doing using this data. So one of the unique things about this data is we have maternal geographic data linked with these stillbirth and live, meaning geographic locations during the time of stillbirth, prior and also prior to the stillbirth. That allows us to investigate geographic disparity, so what areas are most affected by stillbirth. I just want to show a couple of slides to tell you what we've done using that data. And if anybody can't hear me, please raise your hand in the back. Try to speak up. So given this population here, again, this is the state of Utah, given this underlying population here, warmer colors indicate densely populated areas. Highlighted there, over there is Salt Lake City, and some of the other metropolitan areas. Given this underlying population, we found a significant cluster of stillbirth, indicated by this elliptical shape here. When you zoom in this significant cluster, you start to notice that this is up and down the west of this line over here. So currently we're in slightly northeast of Salt Lake City. So this cluster is happening in the southwest of us, and a little bit in the north, in the city of Ogden, here in West Valley City. Again, the density numbers, these are numbers of counts of stillbirth, accounting for space-time clustering. And these are sparsely populated would be in blue, and densely populated would be in warmer colors in yellow. And Rebecca is one of our geospatial analysis experts who has helped us in this project. When you look at the estimated risk, so for individuals living in this cluster that I just showed, there's a 1.2-fold increased stillbirth risk associated with that compared to individuals or families living outside that cluster. And this data is currently unpublished. We're working with our resident, Dr. Dublin, and our medical student, Kennedy, to get this data published. Importantly, this cluster really highlights the areas that might be underserved and important to look into for intervention. And we're currently trying to understand what explains this cluster, and also try to relay some data, air pollution data. Is it access to care? Is it persons living in highly pollutant contaminated areas? And is it racial and ethnic disparity? Is it historic redlining, and so on? So to that end, we're collaborating with Dr. Deving, who's one of our providers, also involved in health policy research and health equity research. Of course, Dr. Zan Lesher was one of our main drivers of stillbirth prevention efforts to try to really understand and expand in other states like Arizona. We heard this morning about the increased incidence in Fort Defiance. Dr. Cohen is one. I'm sorry, I don't have her picture on here, but She's one of the providers at Work Defiance, who's also collaborating with us to understand geospatial clustering. And Dr. Equalito is also working with us. We're also expanding this kind of work to include the state of Georgia with the help of Dr. Christensen Lindquist. Dr. Naomi Reaches, you'll hear from, is interested in looking at environmental contaminants. And this would be critical. So this kind of collaboration is really important when you think about guiding policies to inform policies, but also to implement strategies to intervene in areas that are most affected by stillbirth. And the other component of this is healthcare expenditure. We know from this is one of our systematic review. We know there's a lack of quality data on economic burden of stillbirth, both tangible and intangible burden of stillbirth. And to address, and part of that issue is lack of quality data that we need to generate using the state records. And what we're doing to address that gap is we're working with experts, Dr. Jared Kunapuk, who's collaborating with us, and his student, Bella Kennedy, our medical student, to address, to close gaps in understanding the psychosocial, the unmeasurable impact, but also the measurable cost that's affecting families. Dr. Rothwell, who's our VP for research, is also contributing to this tremendously. And we also heard from Dr. Hazel, who's helping us, was way ahead of us in generating this kind of cost data, quality data. And we're really fortunate to have him collaborate on this with us. And I'm sorry I didn't mention Stacey Fletcher and David Haynes, who have really played an instrumental role in connecting us with other folks who are working nationwide, working on generating quality data. So all of this to say is we have a common goal. If we want to generate quality data for stillbirth, like it's being done for other issues like cancer and late-stage diseases. And there's no reason we can't do that for stillbirth. And there's really three-fold for equitable investigation of stillbirth. We have demonstrated that the added benefit when including dads and family members to investigate genetic causes or causes of stillbirth. And then we are also generating data to address environmental contributors to stillbirth and also economic and psychosocial burden of stillbirth. And this is really the only way to do this is to have population-based data and collaboration across institutions. And this is not exhaustive names, but I just want to emphasize the teams that are helping us achieve our goals, the staff and the clinical team and the research team as well. And we're also funded by the NIH and a couple of foundation grants. And I encourage families to participate in our familial genetic determinants of stillbirth study. And I urge people to contact our investigative team to get involved in that as a parent. But as a researcher, you feel free to contact me, take a snapshot, and contact me to collaborate. So thank you very much.
Hello, my name is Naomi Richards. I have a cold, so I'm sorry if I sound like raspy. But today I'm going to be talking to you about improving equity through the use of the Stillbirth evaluation and decision aid. Is that better? Full disclosure, this project actually wasn't started off as an equity project, but it's very easy to see how this could hopefully improve equity. So earlier today, Dr. Jarwish kind of discussed about the mental health impacts of a stillbirth. You know, mothers are about 2 to 8 times more likely to experience mental health outcome than someone that's had a live birth. And then we had a wonderful panel who talked about the stillbirth evaluations, the autopsy and genetic testing, things like that help classify stillbirth. But these can also help parents deal with their loss. And sorry, apologize. Unfortunately, as also mentioned earlier, these evaluations do remain underutilized. And about 21% of stillbirth skin autopsies are. So here, Dr. Jessica Page, who was talking to us earlier today, had done an evaluation. This is unpublished, but hopefully it seems to be published. And this is looking at how many people in the different categories are offered stillbirth, and those who have choose to get one by the different race ethnicities. And you can see here that, among Pacific Islanders, this particular group is has more than double the rate of stillbirths, but are getting far fewer autopsies. And this is some of the things that we'd like to know about. What are the reasons for declining an autopsy, and how can we potentially improve that? And so, one of the reasons why making a decision is really difficult is for the obvious one. It's a really challenging time. You're grieving. It's a very highly emotional place. And so the process of making a decision when under duress is not necessarily straightforward or purely rational. You've got high levels of stress with reduced rational decision making, as well as reduced memory information. And this can interfere with that ability to weigh the costs and benefits of making a decision. And so a lot of times what people do is they'll pass on a better decision for one with immediate rewards. So there are other factors, of course, that impact an individual's decision making, and this is how they process their emotions, individual interpretations of the situation, their personality traits, and cultural background. So now all of these variables are compounded when you're also dealing with health literacy. Health literacy, for those of you who don't know, is the ability of a person to find, understand, and use health-related information. Low health literacy impacts participation in the decision-making process, and it can actually reduce the it can impact their health outcomes. So individuals under duress, so now all of this can lead to worse health outcomes and is more apparent in minoritized or lower socioeconomic individuals who are also dealing with other health disparities. And this is where a decision support tool can come in. So a decision support tool, sometimes I call decision aids. I'll probably just call it a decision aid for the rest of this talk. These are tools that help patients make a decision when they want their best option. And this image right here, I borrowed this from the Ottawa Decision Support Framework and kind of altered for a little bit for simplicity. So these decision aids are meant to help clarify the decision that's being made to the person, because sometimes an individual may not even understand that they have a decision. They increase knowledge about the decision they're making and clarify personal values. And hopefully the outcome is an informed, value-driven decision where a patient feels supported. And another aspect is that with a decision aid, sometimes this facilitates conversation with a provider and can improve shared decision. So for the aim of our study was we set out to create a decision aid for stillbirth evaluations that was informed by parents. For our methods, so we recruited participants who had received stillbirth care at the University of Utah. They had to be greater than 18 years old age. And unfortunately, I only speak English, so all these interviews were done in English. And this could actually impact the accessibility of this to people that are non-native English speakers. Invitations about the study were emailed out to eligible patients and then followed up with a phone call about 2 weeks later. And then participants could opt out by email or phone at any time. So it was a qualitative research study, and we used a semi-structured interview guide to help facilitate phone conversations. And questions were centered around, what were the facilitators and barriers to getting stillbirth evaluations? We also asked for recommendations to create a stillbirth decision aid. And we recorded these, we audio recorded these, transcribed, and then uploaded to the software to use for qualitative content. And for our results, so we had 19 participants that were interviewed. They were mostly white, well-educated, and of higher socioeconomic status. So again, this could impact the reach of our decision aid to both people, minoritized and non-English speakers. 13 out of the 19 participants chose to get one or more of the stillbirth evaluations. 4 chose not to get any of the evaluations, and 2 were not offered. We asked participants why they did or did not consent to getting either autopsy, Tsegaselassie, or genetic testing. And these are some of the barriers that we identified. They wanted to protect their baby from harm. They wanted to spend more time with their baby. Cost, or the most common was actually they believed they already knew the cause of death before they were even offered exams. So unfortunately, as we heard earlier, some of these are based off of misconceptions. The image of the CSI crime scene where the autopsy is, mutilates a baby. That's not true. Here at the University of Utah, we covered the cost, and that also came up. So this is something that hopefully can be corrected in the future. Top facilitators were having strong belief in science, wanting to inform the information to inform future pregnancies, altruism, basically wanting that information to help others, simply wanting to know why. And then we did have one woman who actually said that they saw the provider treating their baby with respect, and they also felt like this was a facilitator to choosing an autopsy. Oops, sorry. So for some reason I can't see what's happening on this screen, but sorry, it's switched. Well, that's okay. I have notes. I can read them out loud. So next we asked for the recommendations to create the stillbirth evaluation decisioning. And the top recommendations that were made by participants were provide a brief description of the evaluation option, a timeline of events that were related to their care and their decision, and cost information. There were a few things that participants felt like should not go into the decision aid, and that was, visuals of the actual procedures and then clinical language. Yes, perfect, thank you. No, we're not. That's okay. So when we did ask participants how they'd like to receive their educational material, and there was a theme that kept on showing up over and over again, and that was basically to slow down. Slow down when presenting the information, and don't rush the patient into making a decision. So when is the best time to educate parents? This would be after they've had the time to process their loss a little, but also while in the hospital. We had a couple of participants that they said they had, they received a pamphlet, they went home, they got a phone call, and they felt like this was not ideal. So we also had a variety of suggestions on the format of how to present this information about autopsy and other evaluations. And the most common was have a one-on-one conversation with the provider or someone who can take the time to really explain their options. Thank you. With some sort of reading material for reference. Other participants also suggested using like an educational video or website, but then there was worry that the information could be, the content could be triggering the visuals. So, guided by the Ottawa Decision Support Framework that I mentioned earlier, we took all of these patient recommendations and actually created a decision aid. And I wanted to just take a screenshot of the first 2 pages. Right from the start, we wanted to be supportive of parents that, they've just been given horrible news. And another theme that kept on coming up was that a lot of parents felt like they weren't validated in their loss. A lot of comments were made to them like, this wasn't, at least it wasn't real baby, or this wasn't, it would have been so much worse if it, baby died after it was born, after it was alive. And so we wanted to incorporate this and acknowledge that they are still parents and they really have suffered a loss. So I also wanted to comment on the design. We didn't want to overwhelm with unnecessary images or extra information that they might not need. So we kept the language very simple. It's easy to understand, and this information is hopefully accessible to those that have lower health. Additionally, we sprinkled a few quotes throughout the booklet, and these are from parents that have gone through this, that we interviewed for this study. And this is to provide, perspective of people that have gone through this experience before. To keep the information balanced, we did include quotes from parents that, chose an autopsy or another evaluation, and those that declined. All right, and then lastly, well, they're not quite lastly, but this is the last page from my booklet here. We didn't go into a lot of detail about the actual procedures. We do give some information, like the incisions that, like Dr. Comstock had talked about before. They're easily hidden with clothing and cap, and so they can still have an open casket funeral. Now, we still had a lot of questions that remain, and so these are things that I hope to answer in the coming years. One of the things that I'd like to know is, will the use of a decision aid change impact the uptake of stillbirth evaluations? I have some decisional metrics like regret, deliberation, and shared decision making that I'm interested in learning about. We do need the providers to be satisfied, so I'm curious, are the providers' interactions improved because of these decisioning? And then lastly, and the most relevant to this topic, to this symposium, is, does this translate to other languages and cultures? And I'm actually really excited because at the end of this month, I'm meeting with the Genetic Science Learning Center. We're going to update this to be Spanish as well. So we're going to hopefully have a new decision aid that we can hand out to people that are not native English speakers. Well, at least for Spanish to start. And so that's the end of my presentation. I'd love to thank my team, especially my mentor, Dr. Erin Rothwell. She's the one that designed and then I'd also like to thank my department, the OBGYN Research Network, the Genetic Science Clinical Center, and especially the Mothers and Fathers.
I'm sorry, Lopez, if you probably know me or at least emailed me at some point. I'm the Senior Clinical Research Coordinator here at the University of Utah. I run a team of 5, and we run about 30 different studies amongst my team, either related to stillbirth or pregnancy loss. So I'm going to just kind of do a quick perspective on recruitment and actual enrollment, because a lot of studies can be done on mass data, but there's a lot more navigating challenges when we're actually enrolling patients face to face. So the biggest challenge is that most things are just done in English. So our consents are English, our flyers are English, our brochures are in English, our website's in English, everything's in English. And this obviously excludes a huge demographic. So this is a big barrier because some places, some academic centers don't actually have translation services to help them translate their materials, but there's also added cost to that. So if you didn't plan ahead on your budget to incorporate this into your study, you might not be able to afford the translation services down the road. And then also it might take a little bit longer to get IRB approval. So if you do have funding and you kind of do it down the road, then you have to kind of submit an IRB amendment and get it redone. And so you're kind of missing this whole timeline where you're not enrolling people that can't speak English. Another option too is interpreters, which are fabulous, and we love all the work that they do. But it has its own challenges as well. This is an added time. We have to wait for them and try to time when the patient wants to be seen. You can imagine, especially with a stillbirth case, we always want to be sensitive to when the patient's ready. And so sometimes it's really hard to line that up with the interpreter, who's also dealing with the clinical demands as well, which should always take priority. And we tend to disrupt clinical flow. Now, clinic is great and they are always so welcome, but busy days and sometimes we're just trying to sneak in. So it's really, really hard when you're trying to get an interpreter to sneak in with you as well. And then there are virtual interpreters too, but this is another barrier in the sense that not everybody has access to the technology needed to have that interpreter services. And sometimes connection can be really poor. And this can really disrupt the whole flow of your consent process and making sure the patient really understands what you're doing for the study, what the study entails, and to make sure that it's right for them. And then, of course, cultural sensitivity. We always want to incorporate that into our studies, but it's not always easy. We really always want to try to get people from that community to help us incorporate this. But sometimes we don't know who to talk to or who to ask, or, we don't want to take all of their time either, because a lot of times they're doing this voluntarily. And so it's just a big barrier for us. So for researchers, what I would say is if you're designing a research study, if at all possible, incorporate parent voice into this. Parents want this. I've heard some people say, well, we don't want to burden the parents, but many, many parents actually find this very healing, as that's been mentioned earlier, to participate in research, because even though they might not be able to find answers for their own situation, many times women have told me, if I can prevent one other woman from having this situation happen to them, that's worth it to me. And they just want to see the needle moved, because so many of them are told, hey, we really don't fully understand what's still going on with this. And most parents are shocked by that. And they're just like, how is there not research being done on this? So parents are thrilled to do this. They want to be a part of this. So for researchers, ask parents, see if they're willing to participate. If you can create a steering committee or an advisory committee, try to make sure it's inclusive of those parents too, and what's representative of your local community or the demographic that you're trying to look at as well. And then for parents, sometimes it's really daunting to even know where to start. So Australia CRE actually did this beautiful, beautiful PDF that you can download for free. There's that QR code. And it's really just about helping parents navigate participating in research, how to really determine if this is right for you and what to expect. Because we don't want anybody to be blindsided by all of this either. And we don't want to cause more harm when we enroll participants. We really want to make sure that they're our number one priority. We want to make sure they're taken care of. And then, of course, many academic centers do some lower studies. So sometimes you can just Google your local one. So like the University of Utah, we have our page right there, and we try to keep it current as possible of all of our current studies. And then another big one, if you're in the US, is join our Stillbirth Advocacy Working Group. We've been trying to create this network in the US to bring all of researchers, clinicians, parents, everybody together to talk about stillbirth. And so we've created this really nice network of 150 people on this email list. So if you're a researcher, you can send us your flyers or your information, and I can send this off to this group. And if you're a parent, we have sent out a few things about, we need parents on this steering committee or this advisory committee for research. But then we also send out current research studies that you can participate in. So it's a nice way to stay in moving. And then lastly, sorry, I probably went a little fast, sorry, Zen. But lastly, I just want to say thank you. I'm always amazed by all of the parents that are just so willing to participate in research. It's truly amazing, and we couldn't do it without them. And we've dealt with parents that at every stage of their loss. I mean, sometimes we're in the room literally hours after they found out their baby has no heart tone anymore. Or sometimes we're dealing with families that have been years and years out. And I'm always amazed by just how amazing these families are. They're just so willing to participate, and they're eager, and they just genuinely care about helping prevent this from happening to another family. And then, of course, I have to thank my team. They're amazing. They stay with us all the time. They're always just hustling and running around our massive campus. And I just couldn't do it without them. They're awesome. And our whole entire research network, all of OBGYN, and everybody in our whole department of OBGYN has been so supportive of our research and creating the center and the symposium. I can't tell you how many people have done us a favor for this to make it all happen. So I'll pass off to Sarah. What's up?
So I just wanted to thank the panel very much. We have one final activity. So thank you so much to the three of you, Dr. Sega and Naomi and Sarah.